That's it. And let's go. Dr. Auradon sent me this presentation. So before starting to look at the Clincheck and analyzing it, we are going through this presentation. It's an adult patient, 36. And, sorry, I'm going back. That's it. The patient comes to the office to correct the anterior crowding, but as far as I know, because the doctor, the orthodontist, she told me that the real thing is that he was not coming by own initiative, rather than pushed by his wife. Such a common thing. I'm sure that all you have heard this sometime. So this is an important thing to remember, okay? Bear in mind that he is not coming by his own initiative. He's pushed by his wife because it's his wife who wants him to correct the anterior crowding. And another very important thing is that it's a second treatment, okay? He underwent an orthodontic treatment some years ago. I guess then when he was a teenager or whatever. Okay, as you will see, patient is class 1, open bite, anterior open bite, bit increased overjet, as midline shift is the lower one that is deviated as far as I know, and presents minor crowding. The curve of SPE is level. It said SPE. If you want to mispronounce it, you can say curve of SPE. It has incisor protrusion, narrow arches with periodontal recessions and convex profile, incompetent lips, and a tongue dysfunctions. Okay, tongue dysfunction and not tongue thrust. This is the patient. For me, upper midline is centered. And as I can see, and it's my opinion, the jaw, the lower jaw, is a bit deviated to the right. Of course, it's a class 2, skeletal class 2. I don't need the theft to see that, is super clear. You see the smile. Okay, now that we are looking at this picture, we can start asking ourselves a question. Does his smile suggest some expansion? I would say yes, his smile. But then we have to check and ask another question to ourselves. Does his bone and soft tissues allow that expansion? Okay, we'll take a look at the intraoral pictures that the doctor sent to me. I would say that if we can expand here, is in a very, very, very small amount. If it was my patient, and we will talk about that, I would not move the molars a single millimeter. And about the upper premolars and the upper canines, maybe if I'm going to expand, it's a expansion that is 0.5 millimeter and moving a bit the crowns to the buccal, but moving also the roots to the lingual, to the palatal side. Overjet picture. And here you have the panel. If you take a closer look at the 26, you see that there's a problem there, okay? So apart of telling the patient and planning maybe a retreatment of the root canal treatment, apart from that, the thing that I have super clear, if it was my patient, is that I'm not moving the 26. Because if the problem of the 26 gets worse, maybe patient is going to think that it's my fault. Look at the lateral X-ray. Of course, it's a dolichofacial patient, short mandible. So it's a class 2 skeletal problem because the mandible, the lower jaw, is short, okay? So it's a surgical problem. Hey, patient, you want to go through a surgical treatment? No, of course not. Okay, then we are going to do our best, but we are just compensating some things, okay? And as far as I see it, here with this kind of patients, we also have two different ways. One way is, I'm going to plan a comprehensive treatment, and okay, you don't want surgery. We will try our best. That we are planning to intrude the molars, trying to get some auto-rotation of the mandible, and it's correct a bit your profile, and this is going to be a long treatment, maybe 1.5 years, maybe 2 years. You want to go through such a treatment? No, no, no. I'm looking just to fix my crowding. Okay, then this is the short way. We don't move the molars, we don't move the premolars, or if we move them very, very, very little, and we fix the problem that the patient is coming for. Take a closer look at the inclination of the lower incisors, and most of all, take a closer look, please, at the bone surrounding the roots, okay? There's almost no bone surrounding those lower incisors. So please don't forget that. So doctor's treatment plan, she decided that the treatment plan is intended to correct the anterior open bite and crowding by means of retroclining the maxillary and mandibular incisors, relative extrusion. I didn't pick up the comments. Okay, I'm hiding the comments for you. But before hiding them, let me know that all you are listening properly, are hearing me properly, and are watching the screen properly, please. Thumbs up or give me some feedback, please. I need feedback, please. Okay. Okay, thank you so much. I'm hiding the comments and I'm going on. Yes, perfect. Okay, thank you so much. Let me do that. Okay, let's go on. So she, the doctor, the orthodontist, decided retroclining maxillary and mandibular incisors, relative extrusion, and intruding the posterior teeth. Buccal inclination of the premolars, crowns until torque 0 and interproximal reduction. But after saying that, she says no molar movement. So we have here a minor or not a minor contradiction. Okay, let's go to the Clincheck, people. Here we have the Clincheck, and we are going to apply the protocol, okay? Remember, always applying protocols. The protocols that we are going to apply is this one, okay? And it's my personal evolution of Manuel Roman Academy's protocol. It's a bit concentrated, like instead of 10 points, I'm applying those 6 points that you are seeing in your screens, okay? Oh, sorry for this mistake. Occlusion real, So let's apply it. First thing, we go to the pictures. I look the initial occlusion at first place before than anything else, because if the occlusion is not properly settled, then I stop here and I don't go on analyzing my Clincheck. But we see here, initial occlusion for me in this case is okay. So second point, instructions for previous Clincheck. Okay, let's see where we have these. Give me 1 second. Okay, here. So what did the doctor tell the system, not just the technician, the system? She said, you treat both arches, no movement restrictions, attachments as needed, keep the initial anteroposterior relation, and improve the final overjet. And in the vertical aspect, the more important thing in this case, improve the open bite, and she will specify in special instructions at the end. No bite ramps, keep initial midline, and don't do IPR in the posterior, okay? In the first clincher. Special instructions, okay? For those of you who cannot read Spanish, I will translate. Dear technician, please don't expand on molars. Expand premolars, moving crowns to the buccal. Close the anterior open bite, combining absolute extrusion and relative extrusion of upper incisors and intruding molars. Second, next thing, don't extrude with poor extrusion, lower incisors. Only retrocline them. Thank you. Okay, so we have read all this and we go now to point 3, comments. In comments, in the comments tab, we can see these comments again, and we can see technician or software comments. And first comment is, there is a vertical virtual jump, okay? So this is the first thing that we have to take a closer look at. Do we really want this bite jump? If we accept this bite jump, that means that we are trying to intrude the molars and auto-rotate the mandible. So this means a complex treatment. And remember that patient is not coming for that. And again, if we remember the pictures, please take a look at the occlusion, the posterior occlusion. In both sides, molars and premolars are almost perfectly engaged, occluded, okay? So do we really want to change this? Do we really want to change this? If it was my patient, no, I don't want to change this. Maybe a minor expansion, giving some lingual root torque to the upper premolars, okay? But I'm leaving the molars unmovable if it was my patient, okay? Next comment about optimized attachments. Okay, they are telling us that we have root control attachments. Look, please, at the 15, at the 13, 34. So if you listen usually to me, if you listen often to my speaks, you know that if there's a root control attachment, I always like activate my mind. Like I put a bulb light and I say, hey, let's see if we really need this, okay? And I am completely sure that in this case, we don't need that, okay? Okay, with that being said, let's go to next point, number 4. Okay, in number 4, we are taking a look. I'm going to the picture again, movement assessment. And you see between brackets that I say records. Why that? Because while we look at the movement assessment, we are always looking at our records. Because remember, the Clincheck on your left, this is science fiction, okay? And we have to transform this movie, this science fiction movie, this fiction movie, in a film, in a movie that at least it's based on true facts, okay? So the way that we do that is going to the reality, and the reality is no other than the records of our patients. So first thing, look at the movements of the molars. Intrusion, a lot of movements in the molar. I have decided, and I'm sure that the doctor that is the owner of this patient, she agrees with that. I'm deciding that I'm not moving the molars, okay? So now I'm writing down my notes, and I'm not I'm not moving the motors. And what I'm doing, making those motors unmovable, is transforming this case into a much easier one. Okay? So look, a lot of points, intrusion, intrusion, intrusion. But I want you now to think about the difference between the movement of 35 and 34, just to learn a very important thing for me. And for those of you that don't know me, I've been working with Invisalign now for more than 12 years, I think 13 years. So I've been learning a lot of things during those 13 years. And one of the things is that even if you have a blue point here in the 35, in the second premolar, and you don't have any point, any difficulty point in the 34, this is not real for me. It's only a line criteria. What do I mean with that? That for me, an intrusion of 0.53 millimeters, half a millimeter, is a lot much predictable than moving the 34. If you go to the table, you see that the root is supposed to move 1 millimeter mesially with plastics. This is really hard. And it's not only hard and it has no point. The thing is that, of course, we don't want it. This is one of the most common mistakes that we can see in our clinics, okay? Those kind of mistakes. But look, there's no point here. It's supposed to be an easy movement. This is not real, okay? The movement of 34 is much more difficult than the movement planned at 35. Okay, just to let you know, because we have to check very deeply our clean checks and look at all these things. Okay, so more movements. We have, again, intrusion here and intrusion here. Okay, for me, intrusion less than 1 millimeter is not a difficult movement, but the thing is that in this patient, we have already decided that we are not going to intrude posterior segments, okay? Why not? Because the patient doesn't want a comprehensive treatment. He wants just to fix his crowding, okay? So let's go for an easy case, please. More things, okay. The pictures, we took a look at the X-rays before, so I think this is done. Next point, point number 5, staging. We're going to look to the staging in 2 ways. First way is the static view. What can we see in this? Of course, I didn't say that, but if we go here up, it's a light package, okay? The doctor, Lorian, she asked for a light package. And for me, this is quite reasonable. We must try to focus this case like a easy case. So if you are planning a light case only for teen aligners, please don't try to intrude posteriors, to auto-rotate the mandible. If you are going to fix the malocclusion in this way, you always have to move to a comprehensive, okay? So important thing, this is planned like a light treatment, okay? Then let's establish not that difficult goals, please. So staging, I said, we see the staging here in a static view. Attachments at first stage, like we always do in short treatments, I mean express and light versions of the product, and no IPR planned in this one. Okay, now we look in a dynamic view. That means that I move it with the play button or like this with the flat, and I'm looking for interferences and round tripping movements to avoid them because I don't want round tripping. Did I say it clear? I don't want round tripping movements, okay? Because they are dangerous. They are not good for the periodontum. Okay, so there's no other way. Maybe in some cases I have to admit a bit of round tripping, but in 99% of the cases, I avoid them completely. Okay, with that being said, let's move on. Okay, I see no interferences, but what I see is, of course, the virtual jump. Look, if we really want to intrude the posterior segments, we are not going for a light treatment. We go for a comprehensive. And what we have to know that this is not real, okay? The mandible doesn't go upwards like if you are going in an elevator, okay? Mandible and auto rotates going also forward, okay? Upwards and forward. So if we really want to intrude and make a minor facial change, we have to admit that it's going to get a complex case, and we are going to use class 3 elastics to compensate the movements of the whole lower arch, okay? But that is not my goal. That is not my goal, okay? Then, last point of my protocol, of the first part of the protocol, point number 6 is final occlusion. Am I going to stop here? No. Why not? Because it's the treatment plan number 1, and I'm changing it because I always change, I always work out my plans. I never accept, or almost never accept, treatment plan 1. So I'm not wasting time here, but if imagine that this is Clincheck like treatment plan 3, and I have a virtual jump. I am not going to take care of the final occlusion because it's not real, okay? When you have a virtual jump, sagittal or vertical, your final occlusion in the Clincheck never represents the real thing. So let's press the button, create modification, and let's start it. First point now is occlusal plane angulation. Let's see that is the right one, okay? We look at this picture. Do you think it's well-oriented? I think so. Number 2 of the point 2 of the protocol, arch form. If you want to work out the form with this tool, you work it out with this tool, okay? I don't like it, and I prefer to move each tooth individually. With that being said, let's move to the point number 3, tooth movement. Always remember with the tooth movement table that you have below, okay? Always with the tooth movement table that you have below. What am I doing? This one, unmovable. Same thing, unmovable. Remember that unmovable and block tooth are completely different things. When I'm making those teeth unmovable, it means that the plastic is going to cover the teeth, but it's going to be passive in all that area. And now, in the premolar, look please at the tooth movement table again. The crown, okay, go to the 3rd row, moves 0.3 to the mesial. That is nothing, almost 0. But if you press the root button, you see that the root of the 2nd premolar is moving 1.2 millimeters mesially. Why do we want that? We don't want that. Remember that this is super common mistake of the Clincheck. It's not the technician, okay? It's the software itself that is doing all these mistakes. Please take a look in the panel. Do we have any problem with the mesiodistal angulation of the 15th? No, not at all, okay? So I can do a lot of things here. I can change with the table, I can write to the technician, okay, but I prefer to do it by myself. one trick that I use is I stay on the tooth and I say, unmovable. Now the tooth goes back to its original position. And now I say, make movable. So look at the table, all the values are now at 0. That means like received, okay? And now I say, okay, I'm the one and I'm the only one, not the technician, never the technician, that knows what I want with my patient. If I'm looking at the pictures and the x-rays of my patient, I see that in this tooth, the only thing I want is a bit of expansion, but very minor, because look here, it's almost nothing. And what can I do? If I press here where I am now, I'm going to translate. So move the crown and, at least in theory, move the root buccally. I don't want this. I want to move only the crown. So I go here and I start, as you see, moving the crown. And what else do I want to do? I want to move the root lingually. So that's what I'm going to do. What's the way to check if I'm doing the things properly? I go to the tooth movement table. I look at these tooths and I say, okay, I'm moving the crown 0.7 to the buccal. I'm moving the root 1.4 in theory to the lingual. This is what I want. I would say that yes, this is what I want, okay? So I work out every single position of my teeth. Now, a lot of red contacts appearing. Why these, if they are unmovable? Because the Clincheck still has the virtual jump that we are going to eliminate in the next one, okay? So, next thing, because of the time, I cannot do all the changes, okay? Dr. Lorien, she's going to finish the case in Clincheck number 2, but just for you to learn, please look at this one. Again, number 13. The crown, look at the table, third row is moving 0.2 to the distal, 0.2 is 0. Now root, 0.3 to the mesial. Does this make any sense? Does this make any sense? No sense at all, okay? No sense at all. So what can we do? We can do two things. Start to changing every value here, or I go say make unmovable, now say make movable, and I do something similar that I did to the other one. I move the crown vocally and I move the root lingually, okay? And I adjust every single position, okay? That's the way to manage every little thing, okay? So, only for reasons of time, I'm doing some of the changes just for you to see how we can manage all this. And I'm making movable. And now I'm asking the technician, writing comments, not to intrude the premolars, okay? In fact, let's do one thing. Okay, if you look at the 34 at the first premolar, lower left premolar, I look at it and I like the initial position. Why don't we make it unmovable? Just like this. And so we have a reference to the position of this one. And now we can adjust it with the 3D controls, or if you don't want to do it, you can write the comments. But my advice is always, if you can, you have to manage every single tooth position with the 3D controls, because then you have the control. Okay, as she said, no IPR, we don't have much space here, and we cannot retrocline. the lower incisors. And retroclining lower incisors, in this case, is fundamental, okay? It's a must that we have to do, okay? So, what can we do? Okay, I said that this was unmovable, but let's make it movable. And now, let's plant some IPR here in the lower posterior. Why? Because I'm looking at my picture and I see that I have enamel enough to do it. If I look at the upper one, maybe I cannot do that much IPR because the teeth look smaller. If I'm in doubt, I go to the Bolton tool and I check, okay? Maybe if I look at the table, we can do it. Okay, but this is up to you, always up to you. Remember, you are the doctor, you are the only one deciding, okay? Only one deciding. So if it was my patient, I would plan IPR also here. Then we will have to check again the final occlusion, of course, in the next Clincheck plan. But you see now, as we add IPR, how things are going to change. But I'm always looking at the pictures, okay? I'm looking to patients' records because this is real life and all the things that you see in the Clincheck are just fiction, okay? Please always bear that in mind, okay, friends? So I plan my IPR where I know I can. And of course, the Clincheck, the image of the Clincheck helps us a lot because we see big, okay? We see big, the shape of each tooth, and then we can customize our IPR. Looking, and of course, looking also the Bolton tool, okay, to individualize, to customize the IPR that we are planning. Look, what a beautiful way to do all these things. And now, okay, thinking, give it a second. A bit more here. Now, let's see what happens. Okay, now we have a bit of retroclination that we didn't have before. Okay, you see it? Let's hide it and let's go here. Okay, I'm planning IPR here, of course, just for aesthetics. A bit more, okay, to close the gap. Okay, as you see, while I'm working the tooth position, I'm changing all the time the IPR and I'm looking also at the attachments. But in the point number 4 of my protocol, I say IPR, occlusion, and attachments, just to go over these points again and see if I have forgotten something, okay? So one of the things that I'm going to do right now is write a comment to the technician, and I'm going to say, I'm going to write it in Spanish, but I'm going to say, please update my attachment, okay? Update them. Dear technician, now they want to be called CAD designers, but for me, they are technicians. One, update. More things. No intrusion. Don't intrude posteriors, no intrusión de posteriores. No virtual jam. Okay. More things. Point number 5, crown height, pontics, and compensators. We have no pontics in this case but we have recession. So maybe we have to ask the technician to cut virtually, to reduce virtually the height of some tooth. If we take a look at the 16 of the upper right first molar, we see that the height crown, the shape of the crown in the Clincheck is not including the recession, the root. So we will have no problems here. But if you find that you have a tooth in your Clincheck that is too high because it's enclaving the recession, then you can write the technician a comment asking to reduce the height of the crown. Also, you can do this with the pontics, okay? But in this case, I don't think we have to put anything special. So last point, overcorrection and timing. I don't think we have option for overcorrection because it's a light treatment, and I'm sure that in treatment plan 2, we are going to have also 14 aligners. But imagine that we receive the treatment plan 2 and we get only 11 or 12 aligners. If you get 11 or 12 aligners, if you get less than 14 aligners, please always ask some overcorrection aligners. Maybe for a rotation, maybe for extrusion, for whatever you want. That ask for overcorrection aligners. And timing, do we have to say something special about the timing? Not in this case, okay? Yes, when we receive the next one, we are going to check with the protocol, with my protocol or with your own protocol, every single thing, and then we will start changing it, okay? That's it. I'm not changing like more positions due to the time only, but I hope that you have learned a lot. And we have 5 minutes for questions. I'm opening the comments. Let me submit the changes. I don't care about the crucial points like now. And Dr. Lorien, when you receive next plan, you contact me and I help you to fix that, okay? So again, I'm opening the comments and you have 4 minutes to ask. You can ask in English, in Spanish, in Portuguese, in Catalan, you choose. Okay, you get the signal. No questions? Okay. I will just to remind you that all this is being recorded and you can access this later in my YouTube channel. Cecilia Vivanco, yes, not only 24 hours. I'm going to put it in my YouTube channels. Okay, you're going to have this available for you till 2035. I guess there are no questions. Okay, then I'm going to say goodbye to all of you. Thank you for being here. Muito obrigado, muchas gracias a todos los que habéis estado. And remember that during the afternoon, I will move all this to the YouTube channel also, so you can watch it wherever you want, whatever you want, whenever you want.